Unfortunately, the previous two talks, you saw that the evidence in the literature is lacking. Now, if I look at the evidence of what kind of doses of drugs should be used in patients with AKI, it's even less studied. So unfortunately, you can see that from the data that the two presenters earlier gave you, that although there were randomized trials in some situations, but despite the randomized trial, you could not reach to a conclusion as to the modality, timing of RRT, and what dose of RRT you should give. And whether oliguria should be considered, although one or two randomized trials, but again, the evidence, meta-analysis, and the evidence suggesting that one isn't very sure. And unfortunately, as far as the doses of the drugs, most of the drugs which have been studied and where you get guidelines as to what kind of dose should be used have been based on patients of chronic kidney disease on 3 times a week dialysis. And when you look at the literature to find out what kind of dosages you should use in AKI and renal failure, unfortunately not many studies. So what I'm going to present you is something of, again, lack of evidence basically. And we need to, the point which is that nephrologists need to look at this data, or pharmacologists need to look at this data intensely and try to study it so that you can get better evidences of usage of these drugs in these patients. And they can be extremely harmful in situations of AKI. This is what I will give you. I give you a background of understanding of how dosages can be determined in many of these situations. Drug dosing in CKD patients on thrice-a-week dialysis has been very well studied and described, and most of the guidelines for AKI also are based on similar kind of studies. You already heard what is the best modality of treatment of dialysis, timing, dose of renal replacement therapy in AKI. It is still being debated, and thus you can find variability in practice. Somebody saying that CRRT is better, somebody saying SLED is okay, somebody says, Dr. Chacko says intermittent hemodialysis is as good, so I don't think you can find faults with any of these opinions because there isn't any good evidence to favor one over the other. Similarly, drug dosing is again a moving target in acute kidney injury and not well studied. AKI patients are more dynamic, they keep on changing from day to day. You may have one kidney function on day 1, on day 2 it could be totally different, and on day 3 it could be totally different. And then you have, in addition, a renal replacement therapy coming in, and that also washes away drugs to some extent, and that adds on to the complexity of these patients. In chronic kidney failure, we determine creatinine clearance or glomerular filtration rate by a formula which is called Cockcroft and Gold formula. There are a lot of estimations of GFR in patients with kidney disease. This seems to be the one which fits in probably reasonably well and is convenient also and can be easily determined. And this is one formula by which you can find out what the kidney function or GFR or creatinine clearance is. The other one is an MDRD formula where you just need the serum creatinine, the age of the patient, and the ethnicity, because this formula has been validated for the US population actually. Unfortunately, it's not been validated for this country as yet. We are in the process of validating MDRD formula for our patients, and hopefully in a year or two we might have validation or correcting sort of this equation, and you might get Indian modification of the MDRD formula. Estimated glomerular filtration is not good for calculating doses in extremes of body weight, especially if you have very lean or a very obese person, and if you use these formula, these are not going to be very dependent. Or use it for drugs which are very narrow therapeutic ranges, especially, say, immunosuppressive drugs. These are very, very narrow therapeutic ranges, so these formula may not be good for using. So you might use an actual GFR, and the actual GFR can be estimated glomerular filtration rate into body surface area divided by 1.73, because most of the GFRs have been sort of standardized to 1.73 square meter surface area. And in AKI, GFR estimations keeps on changing on day-to-day basis, and therefore you might have to keep on calculating the dosages of the drugs on a day-to-day, so that you can understand the difficulties of determining what kind of control, electrolyte balance, acid-base balance, and considers it to be a support rather than as a renal replacement therapy. And this is a concept which Dr. Ravi Mehta brought in, that renal replacement in patients with AKI should be considered in form of a sport, a renal sport or a body sport as such, rather than only as a replacement of renal function. And it's the thing that he built on was that it provides support to other organs, and the timing of intervention, as was said by Dr. Chacko, should be based on individual need. His last slide showed you that it has to be single patient. So the physician has to keep a day-to-day record and then decide based on output and many other parameters whether it's good to start the renal replacement therapy in that patient. It can't be a general rule of the thumb, especially in AKI settings. You could have general kind of formula for chronic kidney disease who are stable, but not for patients who are with AKI. And the indications for dialysis also can be broad. It may not be only solute removal, fluid removal. There could be many other advantages. And Dr. Jasuja talked about sepsis and high volume ultrafiltration in these patients also. That could be also one of the indications. And the dose of dialysis obviously is again targeted to overall support rather than determining the general kind of formula based. The dosing of the drugs also should be, the pharmacotherapy in AKI should also be supportive actually. And extracorporeal therapies compound the effective drug therapy because you have variable clearances in different types of RRT. Actually, most of the guidelines or the normograms which you get for drug usages, which all of us use, when you look at the RRT, whenever you are doing a CRRT and you look at vancomycin dose, what should be given once in 48 hours, now, this has predominantly been determined on the CRRT flows of 1 liter, which is about 20 or 16 ml or 17 ml per kilogram per hour. That's the usual kind of thing. But you will realize that over the years, the ultrafiltration rates and the dialysate flows have increased, and we've started using more than 20 ml or 16 ml. Sometimes we use 25 or 35 ml per kilogram per hour, and that's when these will change. And therefore, there is a problem. So you must also take into consideration, whenever you are using these drugs, what is the flow of CRRT that you are using, the dialysate flow? Are you using SLED, which is slow extended daily dialysis, or prolonged intermittent renal replacement therapy, to put it into the same kind of naming profile as CRRT? Or is it an intermittent hemodialysis, or is it a high flux dialysis? So all these need to be taken into consideration when you look at the dosages of the drugs. In general, we tend to avoid nephrotoxic drugs for recovery because recovery of renal function is an important component in AKI, and therefore we do not use many nephrotoxic drugs like aminoglycosides or amphotericin, and we prefer beta-lactams or echinocandins in such kind of a situation. Even though there may be indication for using both of the aminoglycosides or amphotericin, but just for the concern of recovery of renal function, many times we don't use it. However, despite this concern, when you look at the audit in the ICUs, and in this study, the Roberts, he found that actually about 1/4 of patients or 40% of patients in the pediatric ICU still continue to get nephrotoxic drugs. There have been some studies which have looked at drug dosing and this one study by Vidal in BMJ, it looked at 4 references for drug dosing, and they were very, very inconsistent in recommendations. In one of the references, 2 references, same drug, it said it's contraindicated, and the other said that there is no dose modification required. You can see the inconsistencies in the references that you have. 4 references, now which one would you follow? And that's the problem in the literature as well, and this is what I was highlighting, that it's difficult. You do not have any guidelines by which you can follow. And how good are these guidelines? Even if there are guidelines, suspect these guidelines. So look at them more carefully. Look at the original data if you are really interested in it, and then try to go for as to whether that dose is particularly good or not, as this reference found out. And most of the information based on dosing information is, again, as I said, in CKD patients and not in AKI patients. CRRT is usually nowadays done in 25 to 30 ml. The things which need to be looked at whenever you're looking at is the alterations in the drug pharmacokinetics. There could be alterations in absorption of drugs. There could be alterations in distribution of drugs, metabolism of drugs, as well as excretion of drugs in AKI. So all of this gets also altered in acute kidney injury. Acute kidney injury decreases the intestinal absorption of drugs because of decreased GI perfusion. There is intestinal atrophy. There is decrease in GI motility. In addition, you may be given either enteral or parenteral nutrition to these patients, which many of these patients are on. So there is a drug, either drug-drug interaction or a drug-nutrient interaction. And as has been documented very effectively, fluoroquinolone absorption decreases when you have enteral feeding. So there may be other things which come into the picture as well. Drug distribution, a process by which drugs leave the systemic circulation and are transported to the extravascular spaces. And the volume of distribution of drug is important actually. And this is the amount of drug which is in the body to the concentration, or ratio of the amount of drug in the body to the concentration of drug in the plasma or in the blood. And there may be alterations in the blood flow. There would be tissue permeability alterations, and protein binding gets altered. There is low levels of albumin in the patients of acute kidney injury, and they also alter the binding of proteins to this. And all of this is altered in AKI patients, as well as when you give CRRT to these patients, further modifications occur in these patients. I give you two examples of these drugs, of drug distribution. Aminoglycosides have a very small volume of distribution. They're not highly protein or tissue bound, and they are dependent on the blood or plasma volume. And now, obviously, if the patient is severely volume depleted of the dose modification, if you use a particular formula, that will be too high for that patient. And if the patient is volume depleted or hypervolemic, and you use the drug formula by a particular method, then that drug will be too little for that patient. So phenytoin, which is highly protein bound in comparison, but the levels of albumin are decreased in these patients. So therefore, a lot of free level drug may be available, and modifications of unbound fraction is the one which is effective. So the concentrations the free may be higher, and therefore if you use the general formula for that level of kidney function, you might provide more toxicity to these patients. Drug elimination is also important, and this is related to both alterations in the metabolism and the excretion. Many of these drugs obviously are excreted through the kidney. They are metabolized, and the metabolic products may be also excreted from the kidney. Some of these may be active and some of these may be inactive products. So these things all need to be taken into consideration. The effect of renal failure on the drug concentration. There is once the kidney is not excreting the drug, non-renal clearances increase. And two examples again for this, say like vancomycin and imipamine, have higher non-renal clearances in patients with acute kidney injury. So therefore, and this is much higher in AKI patients than in CKD patients. So therefore, when you use the drug formula derived from CKD patients, you will underdose these patients when you use these drugs in acute kidney injury. So you have problems there as well using the same formula for these kind of things. This is one kind of guideline which is available, and you can see that this is with whether you're using CVVH or CVVHD. It's important because some of the drugs dosages might get modified because you add a hemodiafiltration or hemodialysis to hemofiltration. So therefore, the dosages may be slightly different, the duration may be different, the dose may get modified, and all those. So in summary, ladies and gentlemen, AKI patients are dynamic patients, so therefore keep that in mind. The general guidelines of using a particular formula for these patients are based on CKD, and therefore you must take it into consideration whenever you determine a particular dose of drug in that patient. Drug volume of distribution must be assessed and must be reassessed on a continual basis, not on a single day basis, that you did it on day 1 and that will not be relevant on day 2 or 3 or 4. Continuously keep on reassessing it. Assess the volume status. Urine output, lab markers of renal function must be monitored on a regular basis. Non-renal clearances in AKI may differ substantially from the CKD patients, and therefore maybe underdosing or overdosing of drugs might occur. Drug clearances by renal replacement therapy likely to be lower in AKI patients because you use lower blood flows, not the high blood flows of dialysis in patients with AKI. And when possible, serum concentration of drugs, which is unfortunately not used in this country as frequently. And I think this is one thing which I would want, wherever drug levels are available, at least in AKI patients, start using drug levels to help you to keep you in the range for therapeutic effectivity and preventing toxicity of these drugs. And whenever you have a highly protein-bound drug, then in patients with AKI, use the unbound fraction or non-bound fraction, because that is what determines the drug activity in these patients. And if you use the protein-bound fraction, that's usually lower, because albumin is lower in patients of AKI. Drug dosing guidelines for CRRT must be ensured. Whenever you're looking at CRRT, look at what is the kind of flow rates and what is the ultrafiltration rate. Now, whenever you are using an ultrafiltration and the patient has zero level kidney function, then you can calculate the creatinine clearance by either the dialysate flow or the ultrafiltration rate. If you combine both of them, that when the ultrafiltration rate is about, say, 2 liter and the dialysate is being also ultrafiltered, then you know that 2 liters per hour is the ultrafiltrate, then you can calculate what is the kind of clearance, because that is exactly what is the creatinine clearance in that patient. And then you can look at a formula and keep on doing it on a day-to-day basis. These are the various resources where you can get help, because these are drug resources are not easily available, and so they should be kept in the ICU. Renal Drug Handbook. There is an Indian edition also available from JP Brothers and medical publishers. There's a drug prescribing in renal failure by William Bennett, and that's published by American College of Physicians. And then there is a website, www.medicinescomplete.com, where you can get sort of all the information about drugs related to kidney failure, AKI, as well as various renal replacement therapies which are available. Thank you very much for your patient hearing.